that conventional glasses and contact lenses do not slow the progression of myopia, and that there are treatment options available is the highest priority takeaway to me, actually. And I think this will continue in 2022 and beyond. Also, when we look at the majority of the studies which were focused this year, mainly most of the studies focused on the impact of COVID-19 on myopia progression. For example, a study done in China reported that the prevalence of myopia in 2020 was higher compared to the previous year's school-based screening, especially in young children between 6 to 8 years. What they did was they did screen children in 2015 to 2019. And then they compared the results with 2020, and they reported that 2020 prevalence was higher than the previous years. And the reason that they mainly attributed was to because all of the kids were confined to their home. So mainly because they were not going out and they were spending a lot of time with gadgets. So these were some of the interesting findings. And another thing that happened in this year was American Academy of Ophthalmology launched the Global Myopia Task Force, comprising various professionals. Similarly, in India, we also took a baby step in forming a myopia task force. Happy to share that OATN is part of that. And this task force came up with an awareness theme to launch a movie to create awareness about myopia among public. And it was recently launched by Union Minister Shri Nitin Gadkari ji. I request, in fact, OATN to share and make use of the video. And moving forward, I think we all have to come together and create awareness among parents, teachers, and all stakeholders. And while on this, I wish to share that SN Myopia Clinic conducted a survey to understand the current practice patterns on myopia management among eye care practitioners in India. Though it was a small sample, what we found was about 25% of them are managing myopia in children. And what it shows is that even among optometrists, the uptake of myopia management is low. So thanks to OATN for organizing yet another awareness session on myopia control, evidence-based approach. And today's session will be handled by Dr. Pavan, who is a scientist researching on both basic and translational aspects of myopia at the Myopia Research Lab in LV Prasad Eye Institute, India. Dr. Pavan pursued PhD from the Queensland University of Technology, Australia, and postdoctoral research from Singapore Eye Research Institute, Singapore. He has numerous publications in international peer-reviewed journals in the field of myopia and has multiple international collaborations. He is also an ambassador for International Myopia Institute from India. And he has many awards and accolades as well. Over to you, Dr. Pavan.
Thank you so much. A very good evening, everyone. Vishwa, can you confirm that you can hear me and see my screen?
Yes, it is.
Great. And if you're seeing my image blurred, maybe I should say that that's part of the defocus strategy that we are in right now. So the topic that was given to me was the myopia control, and the emphasis should be on the evidence-based approach. Before we jump on to the topic, thank you, OATN, for giving me opportunity to speak on this important session today. Ellarukkum vanakkam. I know a little bit of Tamil, so I thought this is a very good platform to show you all my Tamil skills. So I sincerely thank the Vizwana Preeta Ramprasad to give me opportunity to talk on this. And I want to start with a quote by Dr. APJ Abdul Kalam, which says, "It is very easy to defeat someone, that it is very hard to win someone. It's definitely very hard to win someone. Now we are here today on the memory of Shri Rajni Turakhia ji, who has won millions of hearts, who is a great leader, visionary, teacher, and a great human. And again, I take this opportunity to thank the associations that have given me to speak today. So the outline of today's talk will be pretty straightforward, like the title indicates. We're not going to talk more of theories. We are not here discussing various papers, but it will be more of the evidence-based approach, and especially what could happen in the clinical setting. So I will be starting with why do we need myopia control or the myopia management based on the evidence base, and what are the control options that we are looking at, how we manage. And for this how aspect, I got about 4 cases that I've seen in the last week at the Myopia Center of LV Prasada Institute. So I will go through the 4 specific cases in detail, and we will see how we have sort of managed. And at the end, I will touch base upon who should be seen in a clinic or when we should be seeing them. Starting with the known definitions of myopia, well, it's an axial elongation due to which the rays sort of focus in front of the eye with accommodation at rest. And the problem with that is the outer coats of the eyeball stretch and lead to a lot of complications. And that's where the myopia management comes into the picture, which indicates the management is beyond mere single vision correction. So as we have seen in the last slide, the axial length elongates. The eyeball is too big for the refractive component, and that's where you see myopia. And only few individuals will undergo such expansion every year or every now and then, and maybe undergo or will be at high risk of the pathologic myopia lesions. So like the slide heading indicates, beyond providing the single vision correction, and we are looking at myopia prevention and also identifying children at risk for the myopia progression and accordingly put them on some sort of anti-myopia strategy so that the pathologic complications will be minimal or nil. So I did a quick search. This is today, 17th of December 2021, 2:14 p.m., maybe 3 hours before or 2 hours before. And this is Google Scholar, and I typed myopia control, and it gives about 2,15,000 results, and it no time, 0.03 seconds. Now let's see what happened just in 2021. Just in 2021, again, the same keyword, and I took 2 minutes, and then in about 0.17 seconds, that 2,15,000 papers overall until today became 7,980. And this is as of today. And this is publications just in the year 2021 with the keyword myopia control. So what this indicates is that, myopia area is evolving and the management protocols are not straightforward. And, it's like every day you get a new variant. Nothing is stone, everything keeps changing. And it's almost like a COVID-19, unless you are updated, maybe you will be outdated very soon, given that myopia is considered as a 21st century's public health concern. The numbers are going to go high, and it's important that we will be updated in this field. So why myopia control? Just to summarize, the predictions indicate that about 50% of them likely to have myopia, and same is the case in Indian scenario. If you heard Ms. Preeta and Dr. Vishwanath, they almost covered my talk. They gave all the numbers that I wanted to show. So we expect that about 50% even India to be myopic by 2050. The problem is that the numbers are increasing, the progression rates getting more evident, with 10 to 20% of them undergoing rapid myopia progression. Now, rapid myopia progression is something of 1 diopter or more. We say it as rapid myopia progression. And we know that if somebody is progressing much more rapidly, then the chances of they developing pathologic lesions tend to be much more higher. and the numbers indicate about 10% to have pathologic myopia. So this is the prediction that we looked at based on the Indian scenario, and we say that about 48% by 2050. And this is based on the publications that we considered until 2020, and then we sort of extrapolated the findings for the 2050. But if some sort of myopia strategy is given, especially in terms of preventive strategy, we expect that the numbers will tilt down to about 30 to 32%. Now, thanks to COVID, the situation is getting a bit worse due to the indoor-centric lifestyle. Given that we all know time outdoors is productive, more near work can trigger for myopia development or myopia progression. Given the indoor-centric lifestyle, maybe we may not see the linear trend, but maybe a bit more exponential. So the numbers that were predicted before COVID of 48% may not hold true, given the current situation or with the way the cases that we are seeing in the regular clinic. This is, I just want to highlight that how the COVID is sort of changing the situation. 2018 to 2019, there was no COVID and the progression was about half a diopter. This is the right eye and the right panel is showing left eye. On x-axis, you got the year of consultation, 2018, 2019, and 2020. From 2019 to 2020, if you see, it's about more than one diopter, and that's why we're calling it as rapid. Previous years, the progression was there, but it's about half a diopter on an average. Now, the average value itself is jumping very significantly, and that sort of worries us. And it's much more need of the hour to really look at how do we control myopia in the clinic or any practice that we are talking about. So now I will be jumping on to the myopia control. What do we do in our clinics, and especially a specific 4 cases, how we sort of managed myopia. I do not want to call it as a success story, but this is how we started off. Now, the goal of myopia control, as indicated in the previous slides, is to manage myopia and provide something beyond single vision correction if needed. And to do that, you need to really look at the holistic approach, not just look at one entity and come to conclusions. Again, the goal should be to control myopia progression, identify children at risk of developing myopia. So which means you are looking at myopia prevention. Do not think that you should be seeing only myopes, but even emmetropes at risk for myopia progression need to be given advices, recommendations, and so that myopia can be prevented. We say that the time outdoors is one of the safe strategy that can be applied. And a lot of times in our clinics, as a first line of defense, we put them on, hey, go back to your home, increase your time in outdoor environment, do less of a near work, and then come back to the clinic in 4 to 5 months. Let's map biometry and see how the actual length is actually changing. So identifying children at risk of developing myopia is precious at this point of time. And there's something called pre-myopia, which means, the kid is emmetropic, but you suspect that there is parental myopia, the kid does a lot of near work, and for the specific age, it's sort of showing minus 0.25 or 0.00 diopters. You feel that, hey, in a year to come, this kid might be at risk for myopia progression or will have some sort of myopia development, and that needs to be followed as well. And very important, irrespective of the age, I think we need to look at myopes in our clinics, given that there is always a risk of the pathologic myopia. So if somebody is 30 years, do not think that, hey, the myopia may not progress, I don't have to see them. There's always a risk of myopia progression for sure. And although the refractive error could be stable for the good 10 years, but doesn't mean they will not have some sort of pathologic lesion at a later stage. Personally, I've encountered a couple of cases where they were 35, 40 years and the vision was stable, refractive error was stable for good a decade. And suddenly the retina sort of started to detach and there's a visual impairment. So it's important that we carefully monitor these individuals on a regular basis. So as I said, we'll go through 4 cases where we documented detailed history, looked at optics, looked at the biometry, and then decided on the anti-myopia strategy, followed up regularly. And then let's see, did it work or not? And what are the lessons that we have to learn from 4 cases? Case 1, we have seen first time in the Myopia Center on 21st of November 2020. So this is about a year ago, and this is 13-year-old individual. So we asked apparent age of onset of myopia, and then kid said since 5 years of age, that kid started to wear spectacles, which means this is 13-year male, so I'm saying he. So he started to wear spectacles from the age of 5 years. So since 8 years, he is on spectacle. Parental myopia, there's no parental history of myopia. Time outdoors seems to be okay, but point to note is that they're going in the evening time. Now I will pause a bit here. Now we ask the patients to spend more time in outdoor environment, but it's also important to understand that if they spend after if they spend in the outdoor environment after 6 p.m., I think it's difficult to really control myopia. You look at multiple hypotheses that say that time outdoors is good because there's more ambient light, the sunlight exposure, due to which the dopamine gets released in the eye, equal to apteric space, etc., etc. So I think while we get the history, it's also important that go into the details of, okay, what time do you spend outdoors? You spend 4 hours, 1 hour, but are you spending during the daytime? I think daytime is important. Number 2, the other point is what location are they in? They say that I am outdoors, out of my home, but I'm in a parking area. For them, it's really outdoor. Parking area with a proper, the concrete wall, there is no sunlight. Now, will that really help? And our own research indicated that, the luminance varies from each location. It's very important to say that time outdoors, preferably in open space, might matter a lot. Now, coming back to this case, so near work was 7 to 8 hours. We also mapped the relative peripheral refraction, saying that a hyperopic defocus in the periphery will trigger for myopia development or myopia progression. So in our clinics, we also map the relative peripheral refraction. In our routine clinics, we only look at central flash, but according to the publications and the evidence, studies indicate that, look at peripheral refraction as well. In relation to the center, where is the peripheral refraction? We usually map at about 25-30 degrees. So off axis, what is the refraction? Is it relatively hyperopic or relatively myopic? In this case, there is relative peripheral myopia. Lag of accommodation is about half a diopter, and the Fourier status was ortho for both distance and near. Sorry, I want to give a disclaimer as well that I took this screenshot from the electronic medical records of LVPI, but I'm assuming that you will be on your laptops and assuming that this will be a bit clear as well. So this is we saw this individual on November 2020. So on November 2020, I had this information looking at, okay, what's the PGP, what sort of refraction was documented previously. So if you see the refraction first time was about half a diopter sphere, moved to 1 diopter. And in November, when we are seeing in a clinic, it's about -1 and -2 in right and left eyes. So going back, this is 13-year-old. Lag is decent. Relative peripheral myopia, Fourier is decent. Time outdoors is good, but it's going in an outdoor environment. No, in the evening time, I mean. And the parental myopia is nil. So we said, let's see how the things will change in next 4 months. We said relative myopia noted with normal lag. And somebody is drawing something on my screen. All right, so we wanted to monitor myopia and the actual length basically after 4 months to see how things will change. And we said, okay, strict environment changes recommended. More time in outdoors, especially during daytime, 7 to 8 of near work, push everything back. and then see us in 4 months. So they came back in 4 months time, and this is March 2021. So November is when we saw, they came back in March. And the prescription jumped from the right eye sort of seemed all right, but left eye jumped to minus 2.75. Previously, it was about minus 2, and right eye was minus 1, left eye is minus 2. If you compare to here, it's minus 1.25, minus 2.75. So we know there is relative peripheral myopia. We waited for some time. We have multiple options. Time outdoor, we tried, didn't work, or environment change as such. We have options in bifocal spectacle, peripheral defocus lenses, atropine strategy. Well, I said there are changes in the refraction, and the kit is doing a lot of near work. There's relative peripheral myopia, so I didn't want to tap on peripheral myopic defocus lenses or any of the lenses there. So I said, okay, if this person is doing a lot of near work, let's sort of try to relax the accommodation, mechanical tension, and see how it functions. So we gave a bifocal spectacle on March, +2 addition was prescribed. And then we said, okay, to start anti-myopia immediately. And we went on with a no-line bifocal, which will not have a demarcating line or a bifocal segment. And also said, hey, well, if the action length still continues to increase, we want to add Myatro or the atropine eye drops as well. So I got Myatro here, but there's Kitro, Myatro, whatever company that you work with, or Myopin. So we said, okay, spend more time in outdoor between 8 to 5. I was very specific, saying that go and spend more time during daytime. And we said bifocal. So they came back in 3 months time, nothing changed, picture perfect. So we said, well, very good. So to continue same spectacles and repeat biometry after 3 months. So if you see, this follow-up schedule is not 1 yearly, but we are looking at every 3 monthly or 4 monthly. So we saw in March, we prescribed bifocal, said, okay, let's see you again in 3 to 4 months time. They came at the end of June, and then seems like pretty much stable, and said, continue with same as is. So they came back in December 2021, as I said, maybe last week, Saturday. And we saw that, right eye sort of stayed as is, but left eye is undergoing some change, about minus 3.5, again, half a day after jump. So we were not sure, well, do we wait and what's the situation, or take a big step? And we looked at the action length, and November 2020, we got the action length, 24.7, 25.58. If you compare it to the March, there is a bit of increase. And if you see in March, we gave a bifocal lens there, okay? And it's about 0.2 mm roughly. Now from March to December, if you map the action length changes, whatever changes happened in just 4 months time, with the help of bifocals, definitely it's sort of controlled. But instead of seeing the changes in 4-month interval, we saw changes in about 8 months, or it's about 10 months, right? March to December. So it's about 9 months time we saw this. So it's good. But still we felt, there are still some changes. Can we be a bit more aggressive to ensure the control is much better? So I said 0.08 millimeter change, 0.19 in 7 months. And refractive error sort of indicated a bit of change. Then we said, okay, let's go a bit more aggressive and then jump on to combination strategy. Atropine eye drops were given on that. So if you look at, again, I want to highlight these changes here. In 4 months time, there was about 0.18. In 9 months time, there is 0.19. So clearly it's working, but do you want the changes to still be happening for some more time, or can you be a bit more aggressive? It's very subjective. We said, let's be a bit more aggressive for some more time. So lessons from case 1 is that bifocals as an anti-myopia strategy seems like it will work. And there is a lot of evidence to indicate that 40 to 50% control in myopia progression, number 1. Number 2, anti-myopia strategy does not mean it will totally be a blocker. 24 millimeters action length today doesn't mean if you give anti-myopia, it's 24 and it does not change. The efficacy that we always talk about, 40%, 50%, 90%, it's compared to a control group. if you don't give anything versus if you give something, in comparison, what could be happening. So I think we should understand that actual length will still continue to change, but with lesser changes could be happening. Now, second point is the treatment was given already for 1 year. And we wanted to see, there's a lot of evidence also say that whatever treatment you give, after 1 year, the efficacy tend to drop down. So we wanted to be a bit aggressive, and then we jumped on to the combination strategy. So we'll move on to the second case. So first case, 8-year-old bifocal was given, and at the late, there's definitely control, but we wanted to be a bit more aggressive at the end, and we topped it up with the atropine eye drops in consultation with pediatric ophthalmologist. Case number 2, this is 14-year-old, and we saw first time on Jan 2021, apparent onset of myopia 6 years, meaning from the age of 6 years, this person is using some refractive correction. Parental myopia is positive. Time outdoors is very minimal. Time near work is a bit too much, about 10 hours. Now both, again, we mapped the peripheral refraction. It indicated 2 diopters of relative peripheral hyperopia, meaning if it's -1 refractive error in the center, as you go towards periphery, we do, as I say, 25 degrees, we found the refractive error is +1. I'm exaggerating this compared to the center, relative peripheral hyperopia. And this is about 2 diopters. A lag is about 0.75, exophoria was noted. Now, if you look at the hour, and we saw on 29th of January 2021, I had these many prescriptions in hand to compare and decide. 2017, it's about -13, -15 and -14. And 2018, if you see here, it's about -15 and -15, not much of a change. But 2018 to 2021, the refractive error jumped from -15 to -19. So it's about 3 to 3.5 diopters is what there was a jump from 2018 to 2021, which means on average, you are looking at 1 mm change. That's what it clearly indicates. 2018 to 2021, it's about 1 mm change in overall 1 year manner, and 29.35 to 30.35. So 1 mm change has happened in 1 year, in 1 year duration, sorry, in 3 years duration. And 1 mm approximately corresponds to about 3 diopters, if you saw. So we said a case of high myopia in both eyes. And this is the case, I believe, seen by my colleague Rohit Dakal in the clinic. And we said the 1 mm change in the last 2 years is noted. And we wanted to immediately jump onto multifocal contact lens. Okay, this is in January 2021. We wanted to jump onto multifocal contact lens and add atropine if required. For now, why we want to jump onto multifocal? Center distance multifocal contact lens or any sort of peripheral defocus contact lens and take the peripheral refraction into account. And that's what we wanted to start. So, but keep in mind that this is very huge power. We're looking at a power of -19 or minus, So we said, let's give multifocal contact lens. On top of that, whatever is residual, whatever the contact lens cannot take, we will provide a spectacle correction. So over the contact lens refraction was performed, and we have given contact lens, multifocal design, on top of that plain single vision as well. Again, the whole purpose is let's play with the peripheral defocus. Person came back in the month of August. So in about 8 months time, in about 7 to 8 months time, and we found that 30.35 actually changed to 30.5. So we said, well, there's 0.2 mm change. But if you look at this here, second line, used CL occasionally, poor compliance, used only for 20 days. What's the point of we prescribing the expensive strategies, counseling, but the person did not use? I said, well, it's very difficult to take conclusion now. Please continue using contact lens and come back to me after you use contact lens. Studies have indicated it will work. Let's give it a shot. So person came back and the actual lens did not change much. August to December. If you look at the changes, 0.2 millimeters were the changes that we have seen. And with use of contact lens, it did not change much. It's about only 0.07 or 0.01 millimeters, and seems like this is working. So we said, hey, minimal changes in 4 months, improved compliance. Let's continue with the multifocal contact lens as is. So now this multifocal contact lens is an anti-myopia. Seems like it's working. There's a lot of evidence quoting good 50 to 70% in the literature. And there's a spectacle version as well. Hoya is here today, and there's MyoSmart lens that's available in India. And they quote about 70 to 80% efficacy as well. So I think the bottom line is, the treatment effect to obtain, I think compliance is important. I will move on quickly with the case 3, apparent age of onset 7 years, meaning this person came to our clinic. First time he was directed to have myopia, 7 years. And time outdoors very minimal. Relative peripheral myopia is seen. There's no relative peripheral hyperopia in this case. Lag is 0.75. Is using material very close to the eye, a lot of near work. I mean, whenever he does near work, he's holding it very closely. And the prescription was about -4.5, and this is 7-year-old. I didn't want to wait. And I said, well, this is 7 year, -4 already. Evidence indicates that if somebody develops myopia at very early age, the chances of they developing high myopia is very high at later stage. 7-year-old -4.5. I said, let's jump on to something very immediately, and we prescribed no line bifocal, given that is doing a lot of near work. Person has come back recently, and the actual length changes were nil. 7 to 12, 7 meaning July, and this is the December last week. Actual length, 6.4, 6.2, 6.1, 3.9 and 3.9. So I said no changes in refraction, no changes in the actual length, continue as is. So I'm saying that my focal do work, and compliance is the key. Quickly moving on to the case 4. This is 8-year young female. This is female 8-year-old. We saw first time in the month of February 2021. I want to highlight the date here. February 2021, we saw this kid who is 8-year only, and we found that relative peripheral hyperopia of half a diopter, rest all looked okay. Note that parental myopia is strong. Both mother and father had high myopia. 8-year-old, relative peripheral hyperopia. So we know what I had in the month of February was okay. 2020 to 2021, -2.75 jump to -4, -3 jump to -3.5. So there is progression. And actual length, if I map, I had 24.12 moving to 24.42, 2.3 millimeters change. Same is the case with left eye. So that's what I have written as my plan of management. Moderate to high risk for myopia progression, relative peripheral hyperopia noted. In view of myopia progression, we want to go with center distance multifocal. Now here is the interesting aspect that comes in. We wanted to give center distance contact lens, but child was not allowing us to insert and remove the contact lens. We did the fitting, but the training was very difficult. This is 8-year-old. There are few people who will take the contact lens very easily, but she was very sensitive. Now, going back in time, we didn't have MyoSmart lens or any sort of spectacle anti-myopia strategy in hand to prescribe. Now, thanks to the industry who are now allowing us to prescribe anti-myopia strategies in the spectacle format. This is the timeline. 24.12 changed to 24.17. And over a period of 1 year, if you look at this, although so what did we do for that kid? Maybe I want to highlight that. So we moved to low dose atropine, but I personally wanted to counteract hyperopic defocus. I had no option, but you cannot leave them as is. You want to put them on some sort of strategy so that you hope that the eyeball will not grow. Over a period of 1 year, if you see, they came recently again 24.12 changed significantly to about 0.3 millimeter. Okay, 0.12 jump to 24.65. This is not 1 millimeter. So this is jump to 24.65. So about half a millimeter is the change that you have noticed. So we said, well, we wanted to try some sort of the anti-myopia strategies previously in terms of optical, but you did not cooperate. Now that the anti-myopia strategy is available for us, so we want to try MyoSmart. So I think mapping various risk factors, hitting on the right target is important. Peripheral defocus, maybe if we had counteracted, we would have not seen such a progression, and spectacle option availability would have been much better, but now we do have that. So I think, as I said earlier, we cannot think that there's nothing available and you want to not do anything. All we want is the expert in anything was once a beginner, and all of us have to start somewhere in terms of myopia control, and confidence is contagious. Once we are up for it, I think we can spread our wings easily. Who needs to be seen in the myopia clinic? Anyone, irrespective of the age, irrespective of the magnitude of myopia. This is not only for high myopes. This is not only for somebody who shows progression. Look at pre-myopia. If somebody has half adapter, see them 4 to 6 monthly is good enough if you have biometer to pick the changes. So I will conclude my talk with the mantra that I said I want to practice. Master myopia management. Understand that myopia is multifactorial. Measure all the X factors. If you have only 2 factors, measure only 2 factors. If you can measure 10, measure 10. Understand detailed history. Map defocus, map lag. If you can. It's not like this is mandatory. As much as you can, measure all the X factors. Monitor every 4 monthly and manage with appropriate myopia strategies. So with this, I thank you for the attention and thank OATN for giving me the opportunity to speak today. Thank you.
Thank you, Pawan. And we will reserve the questions for now, as Petri needs to leave. So we will. I request you to stay back, Pawan, so that we will have the questions towards the end.
Sure, thank you.
Purnima, you can take over.
Sure, sir. Thank you, Dr. Pawan, for an excellent talk. I now welcome our Joint Secretary, Mr. Samuel Vijay, to welcome Petri.
A very good evening to one and all. Am I audible?
Yes.
Yes, Samuel. Please go ahead.
Okay, thank you. A very good evening to one and all. Firstly, I welcome the Hoya team on behalf of OATN on this memorial session. And my warm welcome and immense happy to introduce our industry speaker, Mr. Petri Eskola, who is an optometrist with the MBA in Health Business Management from Metropolia University, Finland. He is also designated as an optometrist in the global myopia team of Hoya Vision Care. He is also responsible for myopia management education. Mr. Petri has several years experience on myopia management scene and is responsible about helping children to see better and fighting against myopia time bomb. So I warmly welcome Mr. Petri Eskola. And in addition, I also wanted to introduce Mr. Shankar Raman, who is in charge of MyoSmart lenses for Pan India and Business Development Manager, and also Mr. Suresh Kumar, ASM Tamil Nadu, for joining this session. And over to Mr. Petri Eskola. A warm welcome, please.
Okay, thank you very much for the kind introduction. I will talk briefly today about the managing myopia together, which is the main theme of Hoya Vision Care in terms of managing myopia, because even if a wonderful product exists, then of course, without experienced practitioners like you in this meeting, the product would be nothing. So you will be the first line, let's say, people in the battle against myopia, and therefore, you are the main gatekeepers of making sure that the children are getting the best possible treatment. So next, I will share my screen, and during the presentation, I will switch off the camera. So I hope you are able to see my screen. If somebody can confirm that,
No,
that would be very helpful.
No, as of now, no, we are unable to see your screen.
Now it's there, yes?
Yeah, yes, we can. Yeah.
Okay, Perfect. So let's start. So the theme today is managing myopia together. And a brief introduction of myself. So my name is Petri Eskola. I'm based in Helsinki, Finland, and I've been now roughly 2 years in the Hoya Global Myopia team, and I'm responsible for the myopia management education, and I'm also leading a clinical trial in the UK, an observational trial, and also I'm responsible for some new product development. Before going into the let's say the product itself, I want to share with you one very important thing, which is related on, what are the goals and the targets of the myopia management. So we are quite often focused on the let's say what sort of treatment we should prescribe, and that is of course very essential in the myopia management. But we should look actually the primary target, which is the first phase in the battle of myopia control, and that's the primary target is of course to delay or prevent the myopia onset. Now, how to do that? The best way is, of course, try to control the modifiable environmental factors. So as a practitioner, our responsibility is to educate the parents and the children, for example, to have a maximum amount of increased outdoor time, or reducing the elements that we know from the science that are contributing to a myopia onset or a faster acceleration of the myopia. So the primary target is to delay or prevent the onset itself. Now then, if things are not going well and we are entering into the point where the myopia onsets and it starts to progress, then we can identify 2 phases. Now that you can call as a secondary target for myopia management, where we do a clinical treatment of myopia progression. That can be through pharmaceutical solutions. It can be done through the optical solutions available on the market. And then the third target in the myopia management, when the myopia progresses, let's call it too much or too high, then of course we are entering to an area where we talk about clinical treatment of a pathological myopia. Now, mainly this is an area where the ophthalmologist can play the main role, and in the primary and secondary targets, the optometrist really plays a key role in treating and managing the pediatric patients. Okay, now, if our primary target, so delaying or prevent myopia onset, doesn't really work, and we need to start move into the secondary target, which is treating the myopia progression, then for that, Hoya Vision Care has a perfect solution for you, and that is called MyoSmart. Now, MyoSmart, as the title says, it's the smart way of treating myopia in children. And our key claim in terms of clinical efficacy is a 60% slowdown of myopia progression compared to a children that is wearing a regular single vision lens. Now, before talking about the technicalities, I want to share this slide with you. This is about MyoSmart global footprint as we have today. And what I can proudly say is that at the moment, MyoSmart is available in almost 30 countries globally. And within this year and beginning of next year, we are opening many markets soon. So basically, what you can conclude out of this slide, that including in India, practitioners are able to prescribe MyoSmart for their pediatric children. And if we think about the efficacy level, we can also claim that MyoSmart is the, let's say, most sold and widest spread myopic defocus lens in the efficacy category where it is today. Now, to summarize, and this was already addressed by the speaker before me, is that what we know today is that standard single vision lens correction is of course, let's say, the main option for many practitioners when they want to correct myopic vision amongst children. However, unfortunately, we know that that is not an ideal case in terms of what will happen in the future developments of the myopia. So what the research is clearly showing that standard single vision correction may actually inhibit or may accelerate the myopia growth within many pediatric patients. So I can share an example from my personal life. I started to practice optometry around year 2000. And on that time, when I was making my first prescriptions to the myopic patients, quite many of them came back to me and told me that, Petri, funny thing happened that, when I started to wear, these single vision lenses for the myopia, for the first time, I felt that my vision was starting to get worse. And every year after that, I had to have like a higher minus lens or even higher minus lens. And I was a bit wondering, 20 years ago, like, well, how can this be? And maybe there's something wrong what they are experiencing. I don't know exactly. And maybe sometimes I was even wondering that whether that is true or not what they are telling me. However, 20 years later, we of course know that these patients were absolutely right. What we see from the science today is that the regular single vision lens accelerates in certain cases the myopia progression. So therefore, as a Hoya, together with the Hong Kong PolyU University, we came up with an idea of an ideal correction where we are using the myopic defocus to slow down the myopia progression. As a summary of the lens layout, which you can see now on the screen, is that you can divide it into two segments. In the middle of the lens, we have an area that we call as a clear zone. And this is a 9.4 millimeter area where no defocus or treatment islands are present. So when the child looks through this area, they are enjoying the crystal clear view on the maximum level. Then this clear zone is surrounded by an element that we call a treatment zone. Some practitioners call it as a treatment donut. And this is an area where we have a 50-50 mix of defocus islands, and in between each island, you have a create an effect where when the child looks through this treatment area, simultaneously, they have a
Petri, we are not able to hear you.
So what we are able to do in the treatment zone is that at the same
Petri, sorry to interrupt. We lost you.
We lost you in between. It's okay now. Please go ahead.
saying.
Petri, we are not able to hear you.
Okay, how is it now?
Now it's okay. We lost. Yeah, now we are able to hear you, but we lost you in between for a minute.
Ah, okay. Something happened with the system, so I don't know exactly what happened. So
Yeah,
I'm sorry for that.
Yeah, you can continue now.
Okay, so basically I want to summarize the treatment zone, which basically means that when you are looking through the treatment zone, the child is experiencing clear vision and the treatment effect at the same time. And this is made because the ratio within a pupil opening is
Petri, we lost you again.
Yes, I'm sorry for this, but this is because there are some Teams notifications coming from the meeting actually, with the Brazilian practitioners where I should be. So you know, this is a mistake from the teams. I'm sorry, it cuts the talk. I don't know why. So so the thing is that you know, in the treatment zone we are able to generate treatment effect and clear vision. Now, if we look at the situation a little bit in detail and we place the lens in front of the eye, what happens is that if the child looks straight ahead, so then you are experiencing a clear vision, meaning that, you know, through the area where you don't have the treatment zones, the light rays are focused like in a regular single vision lens on your retina. So that's the starting point for a vision in the child. Then if we move into the situation where the child rotates the eye either to left, right, up or down, the following thing will happen. So what happens in here is that when the child is looking through the treatment zone, there are light rays that are going through the treatment islands. And these light rays are focused in front of the retina, creating the myopic defocus. And the light rays that are going between the treatment islands, these light rays generate a regular focal point of a far power, and they are focused on the child's retina. So basically what it means is that you have an array of light rays that are projected in front of the retina, and these light rays are going through the defocus islands, and in between light rays, they are focused on your retina, providing the clear view. So that's the simple technological execution of a very effective method. Now, when we look at the clinical evidence, I want to showcase two elements here today. First of them is our 2-year randomized controlled trial that was published in 2019, where we had 138 children. And out from that clinical publication, we have formulated our clinical efficacy claim, which you can see on the screen. And that clinical efficacy claim means that the MyoSmart lenses with a DIMS technology will reduce myopia progression on average by 60% amongst the children. So that's one of our main evidences. And then one of the more recent one is a 3-year follow-up study results, which is really important for you as a practitioner, because what you want is a treatment sustainability and treatment predictability. The worst thing what can happen is that you don't know exactly how the product performs or is expected to perform. So you want predictability, you want sustainability, and the 3-year follow-up study showcases that very well. So first of all, we had 120 children which went through this 3-year follow-up time, and the results we published beginning of this year in a British Journal of Ophthalmology. Now, the two key learnings that can be drawn out from this publication are that the children who had been wearing the MyoSmart lenses for 3 years clearly demonstrated that the myopia progression is sustained, or let's say the effect is sustained. And then we had another interesting group I want to explain a little bit in detail, is that the children that were switched to from regular single vision lens into a MyoSmart lens showed a significant slowdown. So let's drill a bit deeper on the results. So here on the screen, what you can see now is a 3-year follow-up of children that were wearing MyoSmart lenses for the 36 months of time. And you can see that the annual myopia progression on the first year, on the second year, and on the third year is very sustained. So virtually you see no difference in the level of myopia progression for the children that were wearing the MyoSmart lenses. And that's really a good news. Then if we look at the same or let's say the other population in the study, which were the children who for the 2 first years were wearing a regular single vision lens, and then after 24 months, they were switched to MyoSmart lenses. What you can clearly see is a really amazing result. So on the first year, the child wearing a single vision lens progressed almost a half a diopter. On a second year, they progressed 0.38 diopters. And then for the third year, when they were wearing MyoSmart lenses, they progressed only 0.05 diopters. And that is quite phenomenal results. If we look this from the actual elongation perspective, now we zoom in first on the group, DIMS group, so the children who were wearing MyoSmart lenses for the 3 years. Again, what you can see is that over the 3 years' time, the treatment effect is sustained, because when you look at the progression on a first year, on a second year, and on a third year, these are very consistent results and very good results in terms of an actual elongation. I come back on this topic a few slides later. Then if we look at the group of children who first have been wearing regular single vision lenses for the first 2 years, and then they were moved for the third year wearing MyoSmart lenses. Again, you can see that on a first and a second year, the children wearing regular single vision lens had a really high level of actual elongation. But on the third year, when they were switched to MyoSmart lenses, the actual elongation was virtually on an emmetropic level. So the two key conclusions, if we look from the myopia progression perspective, is that over the 3 years of time, the myopia progression with MyoSmart lenses is shown to be very stable. And we are able to also demonstrate over the 3 years' time the sustainability of the treatment effect, which is not always the case when we look at the myopia management solutions. We can often see that the first year is very effective, but then on a third or fourth or fifth year, let's say, the effect will be faded away. Now, this is not the case with the MyoSmart. And then again, if we look at the children wearing first the regular single vision lens and then switch to MyoSmart, we can see that there's a significant slowdown effect, which basically means that, you know, even if you are not able to prescribe the first pair of MyoSmart lenses for a child, so that the child starts with a regular single vision lens, still there's a treatment effect after you switch the child to a MyoSmart lens. And then final thing, what I want to talk to you about is related on the actual elongation. So it's a little bit busy slide, but let me try to explain what is happening in here. So based on the 3-year follow-up study, here this black line shows the actual elongation of let's call it a control group. So the children who was wearing regular single vision lenses, and then this dotted line is a calculated progression. So as you can see, very high level and very aggressive actual elongation. Now here, what you see as a linear line is a calculated emmetropic eye, let's say a growth curve of an emmetropic eye. And this is based on the publications from Turakhia from 2021. So basically, this is an ideal scenario for a child in terms of an sustaining emmetropia in the eye. Now here on the dark blue, you can see the DIMS treatment group actual elongation over the 3 years of time. And you can see that this curve is actually either on the same level as an emmetropic eye growth curve or below. Now, what does it mean? It means that over the 3 years of time, the clinical evidence shows that, you know, from the aggressive outside of the normal growth curve, MyoSmart is able to restore the eye growth levels on an emmetropic level. Of course, if the child is already myopic, we are not able to reverse myopia back to emmetropia. I mean, every diopter what the child has gained in terms of myopia will be, of course, there, but we are clearly able to show that the lens for the remaining part when the child is treated is not having beyond emmetropic growth curves, or let's say progression in here, which is really important result in terms of controlling the myopia and sustaining the growth on a normal level. So that's all in a nutshell from my side. I thank you for the opportunity to present. If you have any questions, I think we can take 1 or 2 questions in here, and then unfortunately I need to leave to another seminar. Thank you very much.
Yeah, thank you, Petri. I think quickly we have about a couple of questions which I will ask you. I think there is a lot of interest among the private practitioners about DIMS lens, and
Yes.
what is it that they want to understand is, when do you prescribe DIMS lens? Suppose if I see a myope today for the first time, should I consider, or should I wait for the next visit?
That's a very good question. And that is a common question from practitioners, regardless of where they are on this planet. So it's not only a question from the Indian optometrist, it's a question also everybody. And to start with, first of all, MyoSmart lens is only available with the power range of plano up to -10 with cylinder of 4. So basically that defines already that you can treat only emmetropic or myopic children. So that's the starting point. And then to your second question is that, okay, when should I prescribe? Well, in ideal scenario, you prescribe immediately when you identify that the child is in any kind of a risk of developing myopia. So what I'm saying in here is that even if you identify that the child has myopia of 0.25 or 0.50, but you already see that there are several risk factors, including both parents being myopic, very little of an outdoor time, all these, let's say, risk factors that we know, then it is highly recommended that you start already using MyoSmart for these children. So I know that sometimes it is difficult for a practitioner to decide, okay, well, I don't know how the myopia has progressed, or has it progressed at all. Now, this concern I of course understand. However, there is no risk of prescribing MyoSmart from the early on when you see the first signals. So there are not any known side effects. There are not known adverse events that would make the practitioner feel that, well, is it risky to prescribe? No, there's no risk. So I recommend to hit the child with a MyoSmart lens as soon as possible.
Okay. I think from your question, I'll take another lead. What is your suggestion to treat a pre-myope in that case? Suppose if somebody is seeing a pre-myope, would you still recommend these lenses, or what is your take on that?
Well, the problem, like mentioned, is that the availability starts from plano. So, if we consider pre-myopes as having a low plus prescription, and you are already like outside of your emmetropization, of course, you should treat already then because the signals are there. Unfortunately, the power range availability for MyoSmart today doesn't allow you to treat children with low levels of hyperopia.
Okay, Petri, thank you so much. I will reserve the non-clinical questions to Shankar later. Thank you so much for your time.
Thank you very much, and have a happy weekend, everybody. Thank you. Bye-bye.
Thank you. Yeah, I think now we'll shift the questions to Pawan. Pawan, are you there? Yes.
Depends on the question that you ask.
Yeah, Pawan, I think we'll start from the first case. In fact, there are a lot of questions on the first question itself. when you say that, you tried bifocal for that first case, and, did you also consider basin prisms for the same kid, or you just started with bifocals alone? Or when do you decide that, whether it's bifocal or basin prisms?
Good question. We did not give the basin prism on that prescription. So basin prisms are usually given with the anticipation that, if you give for orthophoric or for an exophoric, if you give a high plus, then, I might move a bit more exo, and then there is disturbance in that balance, and that might trigger for myopia. So we did not give, as of now, until now, we did not give. And I know this is not commercially available in India, like Myopilux have launched these lenses elsewhere. So, but we did not prescribe on that yet. Okay, so you also, just to add, the studies have also indicated that, if there is ESO and myopia progression, bifocal sort of gave greater efficacy. So if there is ESO and there is myopia progression, a bit of lag, I think the bifocal is best bet straight away. If there is EXO, you have to be extra careful to bring in that element of bifocal prescription with the prescription. Yeah. So in the same case, you said you have also tried the combination strategy in the follow-up visit. At the last, in the December 2021, yes, after 1 year. Okay. Yeah. So when do you really decide a combination strategy usually? Okay, I think it's very sort of subjective, if you ask me. In that specific case, there was approximately about 0.18 to 0.2 millimeters change in actual length. As per the age of that child, I think it was 13-year-old. So I was thinking, well, 13-year-old, it should be stabilizing, but now 13 to 15 year, I'm still seeing 0.2 mm change. Maybe I want to be pressing the accelerator a bit more. So that's where I took the call. But I think combination, you're asking the combination, I think if you have looked at that case carefully, look at the age, look at the progression rate at which it's happening, and look at the age matched. Okay, stabilization age, I mean, if let's say this is 7-year-old and 0.18, I would be much more aggressive, if you ask me. But this is 13, 14-year-old, I'm thinking, okay, should have stabilized, but the changes are still happening, so I want to tap it on. Okay. You also touched upon that in each of the cases, you did measure the peripheral refraction. Right. And a question on that is there any magnitude of relative peripheral hyperopia that you would consider? You said from the center to the periphery, you try to understand, but is there any magnitude that you understand and then sort of treat, or? Yeah, so whatever the questions that you are asking are very important, and whatever I am speaking today, these are all my opinions. That's a big disclaimer that I want to put in before I speak anything. Sure. So the peripheral refraction, even with 0.25 or half a diopter, I would jump on looking at defocus lenses in the periphery. Now, reason is because if you give a full correction single vision lens, although you said that, okay, everything is now on the retina, during distance viewing, there is still hyperopic defocus of 0.25 diopter sitting in the periphery. So that could still trigger, number one. Number two, we also say that during near work, there is lag of accommodation of good 0.751 diopter, which means for distance, the relative hyperopia is only 0.25, 0.5. But during near, you add lag of accommodation and then that relative peripheral hyperopia, it gets very obvious. So yeah, 0.25 half a diopter is good bet. Okay, I think the next biggest question that everybody who is viewing here wants to know is, as a private practitioner, if I want to start myopia management, what is it that I need to do as a practitioner? Where to start, how to start? Okay, I think the answer is straightforward. Whatever you have right now in your clinics, that is sufficient. If you have a regular optometry practice with You can assess visual acuity. You can do the retinoscopy. If you have autorefractor, I think it's deal done. 50 to 60% of the information comes from there, and the remaining comes from detailed history. Time outdoor, time indoor, parental myopia, and you will be doing cover test. You can assess the phoria, tropias, and then see what's the status on that is. The extra element that's only we are adding is, can you also record the actual length? If you cannot, that's okay, because your refractive error is still sufficient. That's it's indicating that there is change. And then you also spoke about the peripheral refraction. It will be good if you have an open field autorefractor sort of setting, but not everybody can have it. It needs a bigger space, etc. We are working on the alternatives. Hopefully soon we will be able to talk more about it.
Yeah. Since you touched upon axial length, I'm not asking whether is it mandatory, but some of the important strategies that you touched upon, there are efficacy which varies from say 50 to 70% or 80%. So in that case, suppose for a private practitioner, if he or she, when he's seeing a patient who is progressing, okay, so how do you decide the strategy? Which strategy would work for that particular patient? Because this is there with every practitioner. Should I consider giving contact lenses, or should I consider giving lenses straight away? Is something that everybody has this doubt. So
I think again, these are my opinions, and please be careful with what I'm saying. Choose what is, understand what is triggering. We cannot be shooting in the dark. Even studies have indicated that the atropine does not work for everybody. Multifocal contact lens or the peripheral defocus lenses doesn't work for everybody. So why do they don't work? And one of the hypotheses is that, why will they work? There's already myopic defocus. You want to give something to counteract that, it's useless. But look at, the person is doing a lot of near work, there's lag, counteract that. If there is very obvious hyperopia, counteract that. You're not finding that or this big atropine, that's the best bet. Even nobody knows where atropine is working, we say at the cellular level. So that could be the best bet. So I think, and at times you cannot find anything very obvious to target. Then leave them with the environment strategy, follow them in 4 months' time, and that might give you some more extra information. So I'm saying that look at what could be triggering, counteract that. Now, contact lens, spectacle, or whatever, it's next game.
Yeah. So you also touched upon, briefly about pre-myopes. Okay.
Yeah.
Very interesting cohort of, individuals. What would you do with pre-myopes? Would you want to treat them, or would you just leave them, just tell them about only environmental lifestyle changes?
Yeah, only environmental changes. See them again in 6 months. Usually we say, hey, your remet come back SOS 1 yearly or whenever you need spectacles, but we monitor them a bit closely than the usual, and then see if we pick up something, and then you can accordingly trigger for your anti-myopia.
Okay. Final one question. How do you give confidence to people or counsel, patients who want to wear overnight lenses? Because it's very tricky to explain it to parents who would want to opt for orthokeratology lenses.
Yeah.
Is there anything that you suggest?
The individuals that have, maybe I will rephrase this. Each individual is very different. The parents' thought process is very different. I'm saying this because there are certain cases where parents come and say, I want orthokeratology lens because I can insert in the night, I can take them off in the morning. I am not worried. I will not be worried because the kid is wearing lenses going around during the daytime. This is easy for me. They are in my control. So there are cases like that. Now, at times people, maybe that is what we should educate them. This will be in your own control, and you will be spectacle free. So they will be happy about that they are not using any spectacle during the daytime. Now, in cases there, you want to give, but they're not keen, and that's where instead of giving just one option, maybe educate them about what are the possible options that you are thinking. A, B, C, D are options, but according to me, I want to target this because I find this. I think then they will be more, instead of saying, hey, this is the option you buy, these are expensive. Now, without proper justification, it's very difficult.
Okay. Thank you so much. It was really
Great.
wonderful to have you, and I think you have enlightened with a lot of these, answers. Thank you so much.
Thank you so much.
Thank you so much. And Shankar, are you there? There are a couple of questions. There are non-clinical questions. Do we have time, Purnima? Can I go ahead?
Please, sir.
How much
You
time?
are enlightening us with myopia, so we are up for it.
Yeah. Shankar, there are a couple of questions for you.
Yes, sir.
One is, suppose I get a MyoSmart lenses, and when I check it on the lensometer, how would it appear? Suppose only the center portion, should I check the power? How will be the treatment zone, the peripheral zones? Would it be different?
No, the lensometer will not pick up the plus 3.5 defocus power because it comes on the front side of the lenses, and it is a design which has been incorporated during the injectant mode. So you will only look into it as a normal single vision or from the back side. So there shouldn't be any problem.
Okay, so you've answered the second question also. So I'll move on to the third one and the final one.
Okay.
Is there any specific frames that you suggest when we recommend MyoSmart lenses, or is it a regular frame would do?
Yeah, so the MyoSmart lenses people can just dispense the pediatric frames, but with certain flat frame kind of a thing, where we suggest the people to go in for a complete flattest frame as possible, with a vertex distance which is less than 10. And we also say that because the frames needs to be flat as 5 degrees, a maximum of wrap angle, which we advise them. And the pantoscopic angle should be completely 0, because we wanted the children to use the maximum of the treatment zone. So we don't wanted people to have a pantoscopic angle frame. So we are expecting the people to just have a pantoscopic angle which is 0, wrap angle of maximum of 5 degrees, and the vertex distance is less than 10. So the frame is as close as possible to the eye, so that they can use the treatment zone maximum to their. Yeah.
Okay. Thank you, Shankar. That's all we have from me. Thank you so much.
Thank you, sir. Thanks.
Thank you, Vishwanathan sir, Shankar sir, Pavan sir, and Mr. Petri for enlightening us with the myopia session. A request to the participants here. Those who are not members of OATN can register with us as member, and for that you can mail your request to us at oatn2012@gmail.com. I'll put the email ID in the chat box. I now welcome Mr. Jinesh Turakhia from the Turakhia family to share his thoughts with us. Welcome, Jinesh, sir.
Yeah, can you hear me?
Yes, sir.
Yeah. Good evening, all. Hi, I'm Jinesh Turakhia, and I'm Mr. Rajni Turakhia's nephew here. I hereby thank OATN team and Hoya to host this scientific session.
Mr. Jinesh, we are not able to hear you. Yeah.
Is it clear, sir?
And now it is clear. Yeah.
Yeah, we are really obliged and thankful for the honor and respect given to my uncle at every walk. He was a visionary and a mentor to many of us. The reason behind this was his passion for the profession. There are many achievements in his optometric journey, commonest being receiving a lifetime achievement. And the achievements was a sheer satisfaction and the pleasure he achieved in imparting and adopting the newer techniques of dispensing. Staying updated and to adopt new innovations in practice was always in his mind. But to achieve this in the previous times was very, very difficult. But now I am honored to be in the midst of some wonderful speakers. This platform has helped us evolve in terms of professional advancement for products and services. Whenever I think of my uncle, I can only think of optometry, and only optometry. This platform is an apt dedication to him. I once again thank you all for hosting this event. I thank you.
Thank you, Jinesh sir. It was a pleasure having you with us. We did miss Snehal sir as well. So please pass on our regards to him.
Yeah, sure. Thank you.
I now welcome our founder secretary, Mr. Kumaran sir, to give the vote of thanks.
Good evening, and it is really a privilege to thank the esteemed speakers. And I would like to quote in Tamil, about our respected, beloved Rajni Turakhia. Yanai irundalum ayiram pon, adi irandalum ayiram pon. When Rajni Turakhia was alive, he has contributed immensely for the optometry fraternity across India and globe, and even after his demise, and still he is contributing today. So I take this opportunity to thank our keynote speaker, Dr. Pavan, Mr. Petrila, who from Hoya, who has contributed, gave us ideas and gave us a lot of information about the products. The Hoya, Mr. Shankar Raman, who the moment we invited him, he has accepted our invitation and come here and shared his thoughts. And Dr. Vishwanathan, who is a founder member of OATN. Thanks, Dr. Vishwanathan, sir. And also, I would like to thank our OATN office bearers and our silent spectator, Dr. KK, and the founder president, Dr. Singaravan, sir, Mr. Singaravan, sir. Thank you once again. Thank you all.
Thanks.
Hello,
Thank you, sir.
Purnima.
Thank you very much.
Thank you, sir.
Thank you. Thank you, everybody.
Thank you, madam. Thank you.
Thank you. Bye.
Bye.
Thank you all.